And I see everyone coming in through the chat. And so welcome everyone. And again, thank you, Vanessa, for the housekeeping rules. This webinar is really important. We understand that there's a lot of health centers and organizations that serve agricultural workers, and the importance of being able to screen and address tobacco use among this population is just key to helping them quit or reduce tobacco use. And through this webinar and with the speakers that have been invited, we are hoping to share tools and strategies that you can use to continue to do the work that you do in serving agricultural workers, and specifically with addressing tobacco use. And so with that being said, I'll go ahead and introduce myself. My name is Missy Gallegos, and I'm a health education specialist for the National Center for Farmworker Health. I've been with NCFH for about a year. I came to NCFH with about 15 years of public health experience. Spent 10 years educating in prevention of tobacco, the risk of using tobacco, raising awareness for youth and adults in the Muskegon County, Michigan area. And so with my time now, I'm working for our National Center for Farmworker Health, and just really excited to be part of the mission to improve the health of farm worker families. We are a nonprofit organization for those that are not familiar with our organization. We are based out of Buda, Texas, which is right outside of Austin. And we do service and collaborate with 174 migrant and community health centers nationwide. So we are that national program providing services to health centers nationwide on the following topics that you see here: population-specific data resources and technical assistance, workforce development and training, health education resources and program development, board governance training, and program management. So a little bit about that health education resources piece. I'm part of the health education and products team. We create so much great resources. They're all available on our website. Vanessa's going to share a little bit more at the end, but I do encourage everyone to surf our website, take a look at those resources because they're really, really great. And so as far as the learning objectives go, we are hoping that everyone here today can gain an understanding of what tobacco is and what the health risks are if you're new to this topic. And if you're familiar already, that we strengthen that muscle to continue to educate the community, specifically surrounding specifically agricultural worker patients, and that you learn strategies and best practices to screen for tobacco use, and that you learn from our panel discussion about the outreach and education and the tobacco cessation interventions that they are using currently to educate agricultural workers regarding this topic. And lastly, on the resources that we create here through the National Center for Farmworker Health, there are 2 resources that I've been working on, and I'm excited to get them ready to release them to everybody here today and to disseminate them nationwide. One is a health center guide. It's going to be about a 4 to 5 page guide with great tools in there and strategies to address tobacco use. And then a patient tool to use specifically tailored for agricultural workers. It's going to be front and back, and it's going to be a door hanger. And I'll be diving into that resource tool a little bit and share the draft and where we're at with that. So here are our panel speakers. We have 4 panel speakers that are going to be presenting today. On this current slide, I'm just going to give a brief overview of their names and introduction, because I'm going to be giving a bio much further when we get ready to do the panel discussion itself. So first we have Amy Taylor. She is a tobacco cessation case manager lead from a police clinic for Trinity Health in Muskegon, Michigan. Catherine Bonouet, and if I mispronounce your last name, Catherine, I truly apologize, but she is the Executive Leadership Center with the University of California in San Francisco. We have Deborah Salazar, Migrant Health Director for the Salud Family Health Centers. We have Maria Cornevali, who will be joining us soon in case she hasn't already, Executive Director with who is a state certified CHW instructor for Familias Triunfadoras here in El Paso, Texas. And I forgot to mention that being we are a national organization, we do work remote, and I am also from El Paso. All right, and so we have our main guest speaker, Ryan. He's going to be really presenting during for the majority of the webinar. But Ryan, his background is he's a tobacco policy and control manager for the Philadelphia Department of Public Health. Has great information. I'll be reading his bio here shortly, but we're gonna dive into a poll here soon. Panel speakers and Ryan, all speakers, thank you so much for being here. Truly appreciate it from the bottom of my heart. And next we have that Zoom poll that I was talking about. This poll is a 3-question poll. It's just to gauge your understanding on the objectives we're going to be covering today. It's really a good foundation for our speakers. And if you can please take this poll. I'm not going to spend too much time with diving into the answers that are given, just really a brief overview so we can see and gauge where everybody is at with the knowledge of the objectives that are going to be shared today. So far for question 1, which is tobacco use disorder can be best described as habit, chronic disease, result of poor decision-making, substance use disorder, or both B and D. And it looks like so far we have majority answering both B and D for the answer for question number 1. And then we have question number 2. Do you use any other tobacco screening tools besides the required UDS uniform data system, such as the 5As? And it looks like 60% said, well, it's still being answered, so I'll kind of let that run through. But as of now, it looks like we're kind of close to a 50-50 here, but with a little bit more saying no. And then third question is, have you utilized or are aware of the 1-800-QUIT-NOW? And that is an automatic yes for that one. So thank you so much for taking the poll. I appreciate everybody doing that. And we'll let it run, or we'll let it run for a little bit. Unless we're good, Vanessa, we can stop it whenever you're ready.
We can move forward.
Okay, sounds good. Thank you again for taking the poll. And I'm going to do just a quick reading of your bio. I did, summarize some of it, but even though I don't capture all, I just want everyone to know that Ryan has such extensive background in tobacco policy and control. And so with that being said, I'm just going to dive right into that. So again, Ryan is a tobacco policy and control manager for Philadelphia Department of Public Health. He oversees several tobacco control and policy initiatives within the Division of Chronic Disease Prevention. These initiatives include the prevention of youth initiation, promoting tobacco-free environments, mass media campaigns, tobacco control policy, and tobacco treatment services. Ryan first became committed to tobacco control in 2003 while serving as a Peace Corps volunteer in Kenya, which I think is just really awesome. Ryan received his public health degree from Tulane University and has certifications of education, tobacco use disorder treatment, and global tobacco control. Previously, Ryan provided inpatient, outpatient, and community tobacco use disorder treatment in hospitals, behavioral health centers, correctional, and substance abuse treatments. Ryan is committed to serving vulnerable populations impacted by the effects of tobacco use. Thank you again, Ryan, for being here, and the virtual floor is all yours.
Great. Thank you, Missy, and thank you, NCFH, for having me today. Really glad to be here with everyone, with all these great panelists as well, old and new. Great to see some old colleagues and some new ones here. It's really exciting for me to be here today and looking forward to our discussion. And also just thank you to Amalia for providing support with translation for this presentation. Without further delay, I'm just going to get into it with everyone. So thank you again so much for having me. And today we're going to talk about providing tobacco use disorder treatment with efficiency and evidence. What we're hoping to discuss today in the time that we have is how we can redefine how we view tobacco use, common tobacco products and health concerns. I was also asked to speak about optimizing clinical workflow for tobacco use disorder treatment, advancing patient motivational level, and then helpful tobacco use disorder treatment services as well. Contextual piece that we wanted to make sure that we establish before we even dive into today's discussion is distinguishing between commercial and sacred or traditional tobacco use. So when we discuss tobacco products in this presentation, we're referring to commercial tobacco use, not the sacred and traditional use of tobacco by some American Indian communities or other communities in the United States. I want to give a big thank you to this great resource, the RX for Change clinician-assisted tobacco cessation training experience is really fantastic. So I'm going to be pulling a couple slides from this great resource, but would really encourage folks to take advantage of this incredible resource. It is free to register, and it has just a wealth of training materials, videos on providing tobacco use disorder treatment, and other resources. So it really is a great free self-guided learning experience about tobacco use disorder treatment. So I can't speak more highly of this resource. It's really pretty incredible. We're going to begin our presentation by talking about different types of commercial tobacco products. So there was a time when the array of tobacco products that were available for commercial use were fairly limited and not undergoing a great degree of evolution or diversification. So there was primarily, once upon a time, more cigarettes, cigars, and hookah. But now we live in a world where there's a rapidly evolving range of products that the tobacco industry is rolling out to the American public. So this includes roll your own tobacco, electronic nicotine delivery systems, also known as e-cigarettes, e-cigs, or vaping products. There's also nicotine gels, dissolvable tobacco in the form of orb sticks and strips, as well as other forms of smokeless tobacco product use. And what's a key kind of takeaway when we're talking about tobacco product use is there is no safe tobacco product. So despite claims to the contrary by the industry or their allies, that one product is, say, a less harmful alternative than another, any of these products have the potential for addiction and certainly the potential for serious health consequences as well. When it comes to the impacts of tobacco use, they are many. And so despite all the effort that has been undertaken to reduce adult and youth tobacco use, and we have made major strides to the point that this is recognized as one of the major public health achievements of the last century, this is still causing or killing upwards of almost 500,000 or more Americans each and every year through a variety of preventable chronic disease conditions. So something that I always emphasize, because I used to do a lot of work on a cardiac unit in a hospital that I worked in, is that according to the data from the Centers for Disease Control and Prevention, tobacco causes more deaths from heart disease than even lung cancer. That's generally pretty underappreciated, that tobacco's impacts on the heart, both in terms of active tobacco use and passive tobacco use for people in the surrounding environment. So this is an issue that is still very much with us as a nation and still causing hundreds of thousands of preventable, costly chronic diseases and conditions. And so it's really important, I think, that we keep our emphasis, our focus, our resources, and our initiatives focused on the issue of tobacco use. Next slide, please. So while tobacco use has declined precipitously across the nation, we broke through the 20% prevalence barrier, which was thought to be unachievable even a generation ago. So that is really dramatic progress and something that should be celebrated and appreciated. Tobacco use still remains higher in terms of prevalence for certain populations that have been disproportionately targeted and exploited by the tobacco industry. So folks with lower levels of formal education, folks living in poverty, certain races or ethnicities, folks with behavioral health challenges, veterans, and our LGBT community members use tobacco still at rates that are much higher than the general population at large. So again, really great national progress has been seen around this issue. That being said, there are still populations that haven't had a seat at the table, frankly, in terms of experiencing the same gains in life and livelihood as a result of declining rates of tobacco use. Next slide, please. So this is something that I talk a lot about with patients that I see in the clinic that I still run in the city health centers here in Philadelphia. But again, a lot of folks who talk about tobacco use may think just about the respiratory health impacts. But it really is, I think the best way I've heard it put by a physician I used to work with, is that tobacco doesn't cause a health condition that someone's receiving care for, it's worsening that condition that someone's receiving care for. So really does affect every part of the body, head to toe, inside and out. Next slide. But I think it's really important, which is less mentioned when we're talking about the impacts of tobacco use on individuals and populations and communities, is not just the physical health impacts, but the behavioral health impacts. So as I mentioned earlier, folks with behavioral health challenges, so serious mental illness or substance use disorders, use tobacco at considerably higher rates than the population at large. They consume about 40% of all cigarettes that are sold domestically in the United States. And there's really ironclad evidence at this point, beyond reproach, that if you combine your recovery from tobacco use with your recovery journey for other substances of abuse and mental health recovery, it improves your rates of abstinence by upwards of 25%, which is considerable. So it is of vital consequences that we, yes, focus on the physical health impacts of tobacco use, but that we also recognize that folks with behavioral health challenges are experiencing pronounced impacts when it comes to long-term recovery, treatment outcomes, and a variety of really, really important focal points within behavioral health care services and treatment. So focusing not just on the physical health impacts, but the behavioral health impacts, and we're appreciating the need for urgency and action on this issue is paramount. A slide that I really like to use a lot from SAMHSA asks us to think even broader, right? And so instead of just focusing on the physical health impacts of tobacco use, how does tobacco create an adverse impact or an impediment to realizing wellness in a wraparound, comprehensive way? So what SAMHSA posits is that being well is just not being ill. Being well is being financially well, emotionally well, socially well, spiritually well, intellectually well. And one can make a rather strong case that tobacco use detrimentally impacts all of these areas of wellness. So one such example is many of us live in parts of the country, for instance, where the price, unit price for tobacco products is considerably high. And so when people are spending in Philadelphia, for instance, if you smoke a pack a day of a premium brand of tobacco product, spend about $4,000 a year on tobacco products, which leaves less disposable income available for food, healthcare, education, clothing, transportation, other needs that people have. So it really does promulgate poverty, especially in places that are already experiencing pronounced poverty, like the city of Philadelphia, for instance. So I've always really liked this framing that the SAMHSA uses when it talks about wellness and how we can tie that back in to tobacco use. Next slide, please. The flip side of the coin is not just considering how much serious, grave illness, right, the tobacco use causes, but I think something that gets less mentioned in clinical encounters with individuals is how thoroughly and quickly our bodies recover as a result of becoming tobacco-free. And so this is just, there's many visuals out there for this. American Cancer Society has great ones, Heart Association and others. But this, when I first learned this kind of blew me away, right? That your healing from tobacco product use begins in as little as 20 minutes after someone's last tobacco intake. And over time, the amount, the reduction in disease risk, but also just the physical health gains that people experience are very pronounced, right? So heart disease, cancer, stroke, risk, plummets after people become tobacco free. And it's kind of this gift that keeps on giving, right? The longer that people are tobacco free, the more thorough that recovery is. And that is true whether people, no matter how long and how much people have used tobacco. But in addition, there's a lot of immediate impacts that people experience, right? So greater, like high, better energy levels, better breathing, better circulation in their extremities. Because frankly, we're not made for this. It's one way to look at it, right? You think of the first time people use tobacco, the first thing people experience when they're 11, 12, 13 years old is you get coughing, you get dizzy. Our body is like, what are you doing to me? What's happening? Right? So our natural state is really being tobacco free. And so our body's inclination, right, is to really repair and set right the damage that tobacco use does, to an individual. So this is something that I think, in my opinion, is pretty underutilized in terms of talking to folks about tobacco product use. Next slide, please. So this is, I know you can look at these slides and hear about hundreds of thousands of deaths, the very serious impacts on physical health and mental health and recovery outcomes. And it can be easy to just give way to just apathy or feeling overwhelmed by this issue. But this is an issue that we have incredible agency and capacity to change. So again, this is from RX for Change. Love this. They talk about how tobacco use disorders, we think of it, is really there's three pillars that sort of gird this issue, right? The psychological and behavioral impacts, the biological and pharmacological underpinnings, and systemic and treatment underpinnings. Now, some of these, right, we have a limited ability as clinicians and community health workers or in various professions to adjust people's genetic makeup, right, to change their genetic makeup that would impact their tobacco consumption. But we have a tremendous ability, right, to ensure that we have protective tobacco and vape-free policies in our institutions, organizations, and facilities. We have a tremendous ability, for instance, to help people rethink how they interact socially with other people around them in a way that is tobacco-free. We have a tremendous ability, right, to help alleviate tobacco withdrawal through medications. So this is a very challenging issue and a very serious issue, but one that we have demonstrated as a nation an incredible ability to change, but we have to go yet further. Because as we mentioned, this is still claiming hundreds of thousands of lives in communities across the nation. Next slide. So the way you see this issue, you may have noticed I'm using the word tobacco use disorder, which is a bit more of a mouthful than smoking cessation, right? But I think it comes to bear. So I show this image a lot when I talk about this issue and say, people can be talking about the same thing, but be seeing the same thing through a different lens from another person, right? So some people may look at this, for instance, and see a rabbit. Some people may look at this and they might see a duck. So again, looking at the same image, but two fundamentally different takes. Rabbits and ducks are very different animals, obviously, right? So the way you see something can really affect how you engage with that thing and how much emphasis or prioritization we place on that thing. Let me show you what I mean. So on the next slide, I'm going to really encourage everybody here to take the word habit when they're talking about tobacco use and send that packing, and to really redefine their language and how they talk about tobacco use. Habit is very, very different than a disorder, but both the tobacco industry and even folks in the lay media and even folks within public health and tobacco control will often refer to tobacco use as a habit. But tobacco use, as we'll talk in just a second, is something very different than biting your nails or not taking the trash out at night on trash night. So I'm really going to encourage everyone here to just bury forever the word habit when we talk about tobacco use. and instead on the next slide, refer to this issue as what it is, right? It is a substance use disorder. It is a chronic disease. It is a treatable, chronic, relapsing condition. And just like asthma, hypertension, diabetes, or opioid use disorder, alcohol use disorder, cocaine use disorder, like these other conditions, which are well recognized and generally widely accepted to be substance use disorders and to be chronic diseases, tobacco use has a component where relapse can be a part of recovery or management, but does not mean that recovery is not something to strive and aspire for, just like we do with recovery from other substances of abuse. It may take multiple management attempts. Not everyone manages their blood sugar on their first attempt for diabetes. And if someone does relapse or have a lapse, we intensify treatment. We do not chalk that up to a treatment failure. And like medication-assisted treatment for opioids or insulin for diabetes, we would not just say, for instance, just take your insulin, but don't worry about physical activity or diet, right? We know that medication and behavioral treatment are the cornerstone of chronic disease management for something, say, diabetes, or something for, in the instance of, say, a substance use disorder. And the same holds true for tobacco use. The rates of treatment success rival hypertension and diabetes, and we adapt treatment to the individual. And most importantly, I think, offer treatment even if someone is less motivated to make a behavior change. And tobacco use disorder is squarely ensconced, if you will, in the DSM-5. So right alongside of other substance use disorders and chronic diseases. But I think we have work to do, right, to see tobacco use through this lens. Far too often, we chalk it up to a habit, which does not accurately define or characterize or capture what we've come to understand in our evolving understanding of what tobacco use disorder is. Next slide. So a common point that often comes up is, we don't have enough time to really do what we like around this issue. Yes, we recognize it's important, but we don't really know, there's so many things competing for our attention and our clinical skills. We don't really have a lot of time for this issue. And besides, most folks aren't, I don't know how many people are really even interested in addressing their tobacco use. Well, let's try to push back gently and respectfully upon that assertion. So this is a great article that I always really loved that looks at a variety of clinical preventive services and rates them by the amount of clinical preventative burden that addressing these preventative services results in and their cost effectiveness. And what you're seeing is tobacco use screening and counseling rivals even childhood immunization in terms of the clinical burden prevented and cost effectiveness. So that exceeds things that we would never miss the opportunity to do in a clinical setting, such as a cervical cancer screening or alcohol misuse screening or aspirin chemo prevention, for instance. So in terms of the time spent and the yield in clinical preventive burden and cost effectiveness, tobacco use screening, both for adults and youth, ranks extremely high compared to services that we would never miss an opportunity to do in a day-to-day clinical setting. Next slide.
We have about 10 minutes more, Brian.
Okay, great.
Thank you.
So in 30 seconds to 3 minutes, how can we turn the tide on the issue of tobacco use? Let's take a brief look. Next slide. So the effects of clinical interventions are considerable. So what you're seeing here is that the more clinicians that are involved in helping folks address their tobacco use, the bigger the impact. So this is not just the work of a tobacco treatment specialist or the physician. If we have the social worker, nurse, tech, aide, the more cooks in the kitchen, it doesn't spoil the soup, it makes a more delicious soup, is what I'm saying. And so I think that's really important because sometimes we just pick one person in a clinical setting and they're the tobacco person and they do it all. And that's great to have, but each of us, by virtue of our experience, background, training, have a different vantage point and approach that we may use in helping pave the way to behavior change for that patient. Next slide. So it's not just the type of clinician, but again, the number. So look at how the rates of recovery increase the more clinicians that are involved. So that is an extremely important message. And that's why in terms of clinical workflow change, what a lot of good clinical workflows will do is have numerous folks within that clinical encounter, each interfacing with that individual around this issue, because it only amplifies the effect in terms of behavior change. Next slide. The good news is the odds are in our favor. So when this is studied and they ask people nationally across the whole country, how many folks are interested in quitting smoking or exploring tobacco recovery? How many people are trying to recover from tobacco use each and every year? It's the majority of tobacco users. Most tobacco users deep down want the opportunity to explore, at least explore, if not embrace their recovery. And the likelihood of that recovery is greatly increased with the help and support we're able to provide. Next slide. So it's really a two-part recovery process. There's the physical addiction to nicotine, and that's treated through medications. And there's the behavioral addiction to nicotine that's treated through behavioral counseling, coaching, and treatment. Next slide. So step one this is from the Ask, Advise, Refer model, which is used pretty widely for brief but effective interventions to treat tobacco use, is asking the individual in a tone that conveys sensitivity, concern, and is non-judgmental. The way I prefer to ask this often has been, do you now or have you ever used any type of tobacco product, including e-cigarettes? Many individuals will not consider e-cigarettes a form of tobacco use. But as we're coming to understand the impacts of this product, it really is important to screen for all forms of tobacco product use and wrap them in to that screening question. And I always make a point to ask, has there been any change in your tobacco use status, particularly if it's a patient that I've worked with previously that is, I'm receiving a new referral for instance. Next slide. Then we come to advising. And it's important that that advising piece, because this is where things tend to fall off in the clinical setting, is clear, strong, personalized, and open-ended. Clear, strong, personalized, and open-ended. One thing that I found really works well is helping you make your recovery from tobacco easier and more successful. It's one of the best ways you and I together can help your doctor help you. It really does convey that team approach that's really vital for gaining traction on this issue. Next slide. And then referring. And there's a variety of resources that are likely available in your region. We'll talk in just a second about the quit line, but some folks will have a preference for something that might be more text messaging based or more virtual, or some folks may prefer a group treatment setting. So referring folks to resources and describing what those resources are. So you can just hand someone a number and say, call this to quit smoking, or it would really be great, I think, to utilize some of the content you're going to get today to be able to talk about the quit line and demystify that for folks, which is only going to increase your likelihood of uptake, right? Not just raising awareness, but utilization, making that vital jump to calling that number and getting that support. Next slide. So for physical treatment, there are 7 FDA-approved medications currently. I think they just phased out the Nicotrol inhaler that has been discontinued. So there were 7, I believe now there's 6. Many of these are available over the counter or through a prescription from individuals' doctors. And they're pretty widely covered to this point by both public and private insurance. In addition, when you combine these medications together, you get a greater pharmacological effect. So the patch and the gum increases abstinence rates over the patch alone or the gum alone, which is something that generally is not as well known among both providers and the patient population. Next slide. For behavioral treatment, again, we've talked about this already, but just to drive this further home, a treatment team approach is vital for helping to get on top of this issue for the patients that you serve. A variety of formats is strongly recommended in the Treating Tobacco Use and Dependence Clinical Practice Guidelines. combining medication with counseling, and a greater duration and frequency. So the more we talk about this in terms of encounter length and the number of encounters translates into a higher rate of recovery. Next slide. So these are the current evidence-based modalities. The proactive telephonic counseling, like the Quit Line, group counseling, and individual counseling with a slight bump in terms of efficacy for individual counseling. But I think since 2008, there's been a general consensus that text messaging services and supports for tobacco use disorder treatment are also recognized as having a solid evidence base behind them. Next slide. And this is, oh, sorry, again. I think we missed one there. There we go. So in terms of what do we do in that behavioral counseling experience, it's really practical problem solving. When you are stressed or when you are driving or when you're around other tobacco users, what do we need to do differently in that environment that is healthy and productive as an alternative to tobacco use, as well as helping people build up their treatment support. Both their clinician and the Quit Line, that's great, but also people's family, friends, coworkers, and neighbors are, again, a solid body of evidence behind this, that this helps people to make that recovery journey, again, easier and more successful. Next slide. This is the New Mexico Quit Line, and there's a map of quit lines through the North Atlantic Quit Line Consortium, which covers all, because I know folks here might be dialing from all over the country. It's a great map that if you just click on that map at NAQC, it shows you where your quit line, what quit line you have, and what are the range of services and supports your Quit Line offers. So this is what the New Mexico Quit Line offers, for instance, for helping folks with tobacco use. But every Quit Line can vary slightly because it's contingent upon funding. But still, this is a great, great resource. I cannot recommend the Quit Line more highly. Next slide. This is some brand new data that we just got from our Quit Line in Pennsylvania, where I work. And what you're seeing is, if folks use the full battery of calls and the free pharmacotherapy that's offered, we can have quit rates, recovery rates from tobacco use of around 33%, which is nothing to sneeze at. That's a pretty great rate of recovery. So it's vital that folks use this full range of calls and also the pharmacotherapy that the Quit Line may offer. And anyone in that state can call 1-800-QUIT-NOW and access that great service. Next slide. So if you're working with an individual and they say, yes, Vanessa N. Lopez, I am ready. I am tired of, just paying through the nose for these cigarettes. I've been wanting to make a break anyway. What do you got? How do I get started? This is what I do exactly when I meet with patients that I serve, is helping them set a recovery start date, usually sometime within the next 2 to 4 weeks, build up their social support, people that love them, are encouraging and supportive and helpful, and stating clearly what kind of support and help you're going to need from that individual. Because remember, some of these folks have never used tobacco or may not have think that their recovery experience is just going to mirror your own. And that may not necessarily be the case, but really bringing in a support network into your effort. Developing coping skills for your triggers. Again, what are we going to do in place of tobacco use in those person, places, moods, and things that are producing urges or craving to use tobacco? Removing remainders and reminders. So creating 100% smoke-free home, vehicle, and workplace. And then talking to your provider, again, physical health, behavioral health, whomever, about medication options and how to access them. And this can be done in as little as 30 seconds to 2-3 minutes. This is exactly what I do every week with patients that I work with in my clinic. Next slide. Clinical systems change is another great avenue. Some of us here might be administrators or working in a role that allows them greater latitude over helping to design and optimize services within their setting. So promoting health systems change is recommended by the CDC again as a best practice for comprehensive tobacco control programs. Next slide. What this would really entail is creating an integrated clinical workflow for that setting that focuses on screening, assessment, diagnoses, indicating tobacco use on the problem list, developing a treatment plan, offering medications and behavioral treatment, and referral and follow-up. Some of these are naturally occurring in many clinical care settings around the country, but some of these are not, so there is weight to including tobacco on the problem list. I can't tell you how many places that I've worked where individuals experiencing very serious tobacco-related health consequences, but tobacco was never even listed on the problem list and is not included in their treatment plan. So to really change clinical health systems, it's important that from screening all the way to discharge and referral, tobacco use disorder treatment is woven into the clinical experience for that individual. Next slide.
And you are close to a little under those 5 minutes, so you just let me know if we can.
Sure. Yeah, we may have to cut it a little bit short, but I know you guys will get these slides afterwards. But when would you like me to wrap up? And I can be sure to do so.
By
Some of the
48.
I'm
By
sorry?
48. By 48, please.
Okay, great.
Okay.
We can do that. And then some of the other content we didn't get to will likely shake out in some of the questions anyway.
Okay, perfect.
Great.
I'll keep
Thanks,
on. I'll go to
Missy.
the next slide. Yes, you're welcome. And sorry.
No problem. No problem. So what if an individual is experiencing hesitation, concern, even anxiety, right, about embarking on a tobacco recovery journey? What are some strategies that we can use to build motivational level, advance that stage of change to help make even that crucial jump, right, from preparation to action or pre-contemplation to contemplation, for instance? So here's a few things to take with you today. Next slide. So a lot of us have probably received training on motivational interviewing. If you haven't, would really recommend, there's lots of great free self-guided learning experiences on sort of basic principles of MI. But the general spirit of MI, as it's referred to, is it's really creating a exchange with that individual that is based on collaboration, not confrontation, evocation rather than indoctrination, and respecting folks' autonomy rather than exercising authority over that individual and their decision making. Next slide. It's important to use open-ended, affirmational, reflective listening and summarization, or our ORs, in that encounter. I really am a big believer in MI, and I have seen the application of motivational interviewing to just fundamentally change the tenor and nature of the conversation with that individual. So for instance, with affirmation, someone would say, I still really like tobacco use. And I will often reflect that, I used to use tobacco myself, in a former life, that, yeah, there are certain things about tobacco use I miss as well. That can be natural, that can be normal. We can still be in a position where I will miss and have a bit of remaining nostalgia for tobacco use, but I recognize that life being tobacco-free holds promise and potential that still, despite that liking of tobacco use, is still driving me to move forward and make a change in my life. Next slide. Elicit, provide, elicit is very powerful. Instead of telling people with the finger wag, you need to do this, you need to do that, elicit, provide, elicit, the basic idea here is that, what have you heard about this particular issue or topic? If there were some additional research or studies, would you be open to talking about this, sharing that with that individual, and then eliciting again, what does that information mean in terms of your behavior change or what you're contemplating or thinking about? I've done this scores of times around how nicotine replacement therapy works and whether it is safe and effective, or it could be concerns over weight gain that people will voice. And it's amazing just how much in a healthcare setting, just asking folks, what have you heard or read? And can I ask you a question or share some more information with you? Just how seldom that really happens in a clinical environment. It just really does affect people's body language and just the degree of engagement in that discussion. Next slide.
Ryan, we are at 48. Do you want me to share any specific slides to wrap up that would be most important that you want to share before we?
No, I think if you guys are comfortable, I'd be happy to make this deck available for everyone. And then, yeah, just out of respect for our other panelists and the great remainder of the webinar that you guys have today. Happy to answer any questions that folks would have.
Okay, let's see here. More slides here.
Yeah, what is the remainder of the presentation is essentially some other tips and tricks and strategies and tools that can be used to build motivational level. And if someone is not interested in exploring their tobacco recovery, how can we use subsequent clinical encounters to build that desire for change? So that's something that is more than fine to share with everybody, as a follow-up to today. And yeah, happy to answer any questions folks may have, and really do appreciate the time to be part of this great event today.
Yeah, no, thank you, and I apologize about the time constraint.
Yeah, no problem.
And I can leave it on some of these slides here in case there's any questions regarding the slides that we didn't get to cover.
Yeah.
But we can go ahead and dive into the Q&A at this time. We do have 5 minutes for Q&A. If there's any questions that anybody has, if you can go ahead and start entering those into the Q&A box. And Vanessa will be happy to read those questions in behalf of Ryan, and then Ryan will be more than happy to answer any questions that you may have for him during his presentation.
Also,
Yeah, if you don't
feel
mind,
free to
Missy,
use the chat.
Oh, I'm sorry, Vanessa, go ahead. Sorry.
No, I just said to feel free to use the chat as well if you would prefer.
Great. Yeah, and if we don't mind leaving the slides up just in case folks ask a question that's covered in the 5 or so remaining slides, that'd be great. Yeah, happy to answer any questions that folks may have about what we discussed today.
Okay, so we do have a question here. How do we encourage our health centers to adopt or implement a new tobacco use screening tools?
Yeah, it's a great question. We're actually in the middle of doing this right now with our city health centers. So Philly's kind of unique in that we have 8 city health centers that serve about 90,000 low-income Philadelphians every year. So I think what I can speak from that vantage point, if that's helpful, but I think encouraging health centers to think about how we can achieve improved treatment outcomes. So that's what kind of got our way through the door. Well, let me back up a second. I think one thing I've noticed with a lot of health centers is they always have like a long list of changes to their EHR and like many demands on clinical practice change. So sometimes there's value in starting with something small, which is what we did in our city health centers. We added like several medications to formulary because for years in Philadelphia health centers, they were only providing the patch. And so we shared the evidence, we shared cost information, we shared the misconceptions about using combination pharmacotherapy with the health centers. And that was the first step. They're like, okay, yeah, we can add the patch and the gum and the lozenge. I'm sorry, add the gum, the lozenge, and other forms of pharmacotherapy to formulary. So once that was accomplished, then it gave us a kind of a jumping off point to come back and say, the populations we serve are greatly impacted by tobacco use. There's a lot of interest in addressing tobacco use among the populations we serve. And by doing so, we can improve physical health and behavioral health outcomes. And then what we had done was just shared, we would be happy to work with you to optimize the clinical workflow in these settings, seeing where the holes or the gaps may exist and presenting suggestions on how we could do so. We also came to the table with some resources. So for instance, in Pennsylvania, they cover the e-referral costs. So if they want to integrate e-referrals to the quit line into their electronic health record, that's covered by the state. So the health centers love that, right? That's a great clinical change. They don't have to pay for it. All they have to do is have the tech people
from here, talk to the tech people from here, and they can make that change. But I think framing how providing evidence-based tobacco treatment, again, aligns us with the evidence base, but it can improve outcomes that they're really concerned about, right? Like hypertension, diabetes, asthma, and offering staff as well as resources to help make that change, you know, technical assistance and expertise, as well as fiscal resources if available. It takes a little time because they'll often say, well, yes, first we got to do this new pharmacy system that we have to get to, or there's these new other EHR changes that we're making. I think you have to be a little bit patient. Sometimes health centers are just swamped and they're just trying to get to a little bit of everything, but just kind of keeping that message going. The other thing that I would encourage would be just doing in-services to health center staff at all staff meetings, or like the pharmacist meeting or the behavioral health specialist meeting, and just talking about tobacco use. The more people are hearing about it, the more people are getting energized around it, the more likely they are to say, when you do approach them with you know, kind of a clinical workflow change or EHR change, they're more receptive to it because their staff have been thinking and talking about it in response to the in-services or training experiences, lunch and learns, what have you, that are being provided. So just a few suggestions there.
Awesome, Ryan. Thank you. I love the in-service idea because, like you said, the more you speak about it, the more you train. It's just really going to be, you know, you're immersing the staff, and I think that's just really great. But overall, really great, you know, options and ideas to integrate screening tools and tobacco cessation interventions within the health center setting. I think you provided some really great responses for that. We are going to transition over to introducing the resource guide, and then so we can dive into the panel discussion. But thank you again, Ryan. There is one question that came in from Stephanie O'Connor, but if you can feel free to answer in the chat,
Sure.
and you guys can continue that discussion in the chat, and then we can move on into introducing the guide. But thank you again, okay?
Absolutely. Thank you all.
All right.
I'll answer Stephanie's question in the chat. Sure.
Yes, thank you, Ryan. Thank you, Stephanie, for your question. We appreciate it. And just really quickly, so that Amalia can translate, I will read the question out loud, but Ryan will be answering that question in the chat. And Stephanie's question is, are you seeing the same percentage of people wanting to quit vaping as quitting previous tobacco products like cigarettes, referring to the 80% of tobacco users that regret starting / want to quit from the previous slides? So thank you again, Ryan, and we'll let you answer that in the chat. All right, so I am back, and I'm going to go ahead and dive into the two resources that I want to discuss today. And I shouldn't take a lot of time with those resources because I do want to give enough time for our panel discussion today. Again, this is Ryan's information before I move on. So if anybody wants to take a picture of Ryan's email, and you can have that as a keepsake in case you want to reach out to Ryan later on and ask him any questions regarding any of the information that he shared today. So the resources that we are working on or that I have been developing have a foundation, a solid foundation of research that's been conducted. The resources, again, for those that came in slightly later, I introduced in the beginning that we've developed, and they're in the process of going into design. But it's a health center guide that's going to be about 4 to 5 pages long that's going to provide tools and strategies to address tobacco use within a healthcare center setting. And then also a second resource that is going to consist of a patient tool. It's a door hanger. It's going to be front and back. It's going to be in English and in Spanish. And again, that door hanger is intended to provide that outreach so that you can go door to door and you can just hang that door hanger on the hanger or slip it between the door cracks. But a lot of research, again, was spent on this, on these resources. We implemented surveys to organizations that serve agricultural workers, specifically health centers. And of the data that was collected was the foundation to the start of these resources, as well as conducting focus groups. focus groups with a group of agricultural workers that are tobacco users, and a focus group with agricultural workers that were non-tobacco users. And so we gathered such great information, and we understand that through this guide, we've educated on how smoking and vaping is detrimental, not only to the individual, but to those around them. So the patient tool is family focused, like not just for you as an individual, but for your family as well. And then again, we're continuing to conduct research on this topic. We are in the midst of reporting and we're going to continue to provide technical training, just like this webinar. And we're going to continue to provide resources. So the resources you're going to see today are in draft mode. Our communications team is going to take them and make them look beautiful and put them into just amazing templates that we're going to be working on creating. So forgive me for what you're going to see next, because it's not a fully finished resource, but it is, again, just in draft mode. And in the guide and in the patient tool, we are focusing on addressing what tobacco is, and so that it contains nicotine. It's addictive. Our data has shared that agricultural workers are vulnerable to use because of the nature of work, because of the constant mobility, the anxiety and the stress that comes with that nature of work. And educating on those health risks associated with tobacco products like Ryan was talking about, and educating and screening, not to get tired and weary, just continue and getting, just don't give up, keep on educating, keep on screening, because through the focus groups, we did learn that some agricultural workers may not want to share because they don't want to share that they're tobacco users, because they don't want to hear the education. But you never know that moment where they're going to reach a stage of pre-contemplation and be maybe in a state of action. So the importance of educating and screening and continuing that is so important. So the guide, I'm going to run briefly through these slides, but in the guide for health centers, your tobacco products, what they are, the risks associated with the use of those products. You'll have multiple products that will be listed in the guide. In the focus groups, there was misconceptions that agricultural workers were sharing about what happens when someone quits smoking. And so those were a bit concerning, and we are wanting to encourage through this guide that it's important to continue to address the benefits of reducing or quitting tobacco use and debunk those misconceptions that agricultural workers are hearing from either their family members or their peers. And so then when it comes to screening tools, Brian mentioned just that overarching compass of making sure that we're screening, we're administering the 5 A's and in addition to the 5 A's, other screening tools as well. And so in the guide, you're going to have an abundance of tools that you can use aside of the UDS that's already being used, but just to complement what you're already using. And they're clickable links that will take you right straight to those tools. And then again, diving into stages of change and motivational interviewing, building that capacity, strengthening that muscle to know what stage of change an agricultural worker who uses tobacco, where they're at, and how you're going to meet them with resources and using that motivational interviewing technique in stages of change. And these links will take you to resources that are related to these strategies that are going to help you implement them and understand them and learn them a bit better. And once we know what stage of change they're in, what resources we can provide. And if it comes down to providing help quit lines, then, what are those bilingual resources that we can use, and, what quit lines we can refer them to that are available in Spanish. And so then building partnerships around your community, what other health centers or what other organizations around you that are nonprofit orgs that serve agricultural workers and serving and addressing tobacco use, because we might be able to come so far, but that's when our referral process comes in. And who can we refer our agricultural workers to when we can only meet them so far, and we've exhausted all resources, and then where do we refer to them next? And so we can provide and support technical assistance to navigate this really neat tool on our website that allows you to search for community partners in your area and the resources that they offer. And lastly, it's that patient tool. It's going to be a door hanger, going to be in English and in Spanish. And again, it's just like a mirror version of the guide, but of course it's simplified, it's in plain language. It's been reviewed by our farm worker committee, and it's been approved as being relatable and specifically targeted for that population. And as far as I know, there's going to be questions as far as when these resources will be ready. When can you see them come out to you? And due to time, I really want to encourage everyone to put your name, your email, and your question you have in the Q&A box if possible, because the Q&A box is anonymous. So we can better keep track of that information in the QA box as well. And I will respond after the webinar, because my goal with this resource guide is to provide technical assistance. So, and if you're interested in getting that technical, please put your information in the Q&A box, and I will make sure to reach out after the webinar. But thank you again for giving me time to introduce the resources that will be available soon and that are currently in design mode. And with that, I'm going to go ahead and get ready to introduce our panel speakers. I'm going to do a brief introduction, a bio introduction for each and every one of our panel speakers today. And I'm going to begin with Amy. Amy has 9 years of experience in nicotine addiction. Amy specializes in providing tobacco reduction support to people living with HIV, combining the whole person approach with pharmacotherapy and behavioral interventions. Catherine is the executive director for Smoking Cessation Leadership Center, and her center aims to eliminate disparities in commercial tobacco use and increase the number of providers who help individuals quit. Catherine works to assure that strategic goals and plans of the center are met, ensuring that the center is at the forefront of tobacco control and prevention messaging and strategies. Catherine has helped create a multitude of national, state, and county cross-sector partnerships focused on driving tobacco use prevalence down. Catherine has extensive background in tobacco control and cessation, which includes 20 years of professional nonprofit and for-profit experience. Catherine is also the chair of the board of directors for the North American Quitline Consortium. Next, we have Deborah Salazar. Sorry, I'm used to calling Deborah Deb for short. But Deborah works with she's a migrant health director for the Salud Family Health Centers in Colorado. She studied sociology and did postgraduate work that she accomplished in alcoholism, addiction, and codependency in the Universidad Iberoamericana in Mexico City. And if I mispronounced the university, I do apologize. But the university is one of the top schools in Mexico. After living in Mexico for 19 years, Deborah and her family moved back to the US to live in Southern Illinois. There in Illinois, Deborah was part of a team that started a migrant health program and as well as a mobile homeless program for 2 years. In 2013, Deb and her family moved from Illinois to Colorado, where she started her role with Salud Family Health Centers. Deborah is passionate about migrant health care and is grateful for the opportunity to promote and advocate for the health and wellness of migrant farm worker populations through her work on the medical mobile unit. Lastly, we have Maria Cornevali Ortiz. Maria Cornevali is the executive director and founder of Familias Triunfadoras. It is a nonprofit organization. She is certified as a community health worker instructor and has certified over 600 community health workers. Maria has over 30 years of working in the community and making a positive change in the most vulnerable communities, making sure that they're reaching and getting information to areas that are most difficult to reach. Maria has received multiple awards. When I was reading your awards, I was so impressed, Maria, but she has received an award on behalf of Barack Obama, the Presidential Award for Volunteer Service. She received a Hometown Hero Award, and much more awards aside of just those two. But Maria, thank you so much. And Deborah, Catherine, Amy, thank you all for being here today. With that, we'll go ahead and get into Amy. Amy, whenever you're ready, have your question here. And Amy, your question is, or statement is, please share your experience using one or two screening tools that have been successful in helping you address tobacco use among your patient population.
Thank you so much, Missy.
Yes, of course.
Thanks. Before I discuss the screening tool that I want to share with you, I wanted to share that whenever I meet with a patient and I want to bring up the topic of tobacco or e-cigarette use, the first thing I like to do is ask permission. I assume that when I meet with someone, they've experienced a certain amount of shame and stigma around their tobacco use, and I feel like starting by asking permission is a great way to start. And the majority of the time, people do say yes, but every once in a while, somebody does say no. And I just look at that as my opportunity to show them that I respect their boundary. And so if they say no, I just say, no problem. I don't want to make you feel pressured. If you end up having any tobacco or e-cigarette related questions later on, please feel free to reach out. Otherwise, I'd love to connect with you next time. And by responding this way, I know that when they return in 6 months or a year, whatever it is, and I ask their permission again, I hope that they remember that I listened to them, and then hopefully they'll be willing to talk with me at that time. So the screening tool that I wanted to share today is the Fagerström test for nicotine dependence. For those of you that work in tobacco dependence treatment, I'm sure you're probably familiar with this. It's comprised of 6 questions. There's scoring on the right-hand side, and there's points that are assigned to each of the possible responses, and you just tick one box for each question. So I'm going to go over the 6 questions with you. The first one, how soon after waking do you smoke your first cigarette? Do you find it difficult to refrain from smoking in places where it's forbidden? Examples can be church, the library, movie theater, on an airplane. The next question, which cigarette would you hate to give up? How many cigarettes a day do you smoke? Do you smoke more frequently in the morning? Do you smoke even if you are sick in bed most of the day? So normally it's a pretty good conversation. I like this questionnaire because through this conversation, I'm able to pick out opportunities to recognize strengths that oftentimes people don't even realize. If they let me know that maybe they don't smoke within the first 5 minutes of waking up, then I'm able to say, oh my goodness, so you're saying you sleep all night long, and then even once you're awake, you're able to go this many hours. And just having the opportunity to tell somebody like, wow, that's really great. They oftentimes don't even realize that they were able to do that. And so that's a great place to start in our conversation. So after I've gone through those 6 questions, I will add up the score. And then there's a couple more pages below. And on the next page, based on their score, I'm able to identify their level of nicotine dependence. And it also provides recommendations for nicotine replacement therapy. Now, this document is a little bit out of date as well. It still shows the nicotine inhaler as a possible NRT option, which we no longer have that. But the rest of it is great. So after we've identified their score, I then will go over that second piece, which is saying, so it looks like you scored a 4, which considers you to have a low to moderate dependence on nicotine. Then I just ask them, like, what do you think about those results? Does that connect with you? Do you feel like that's accurate? We'll have a discussion around that. And, this leads into the things that, Ryan had covered. You're asking about their tobacco use. You're advising them, hopefully in that conversation, and then referring to possible ways that they can receive treatment for this. What I really like about this tool is you're starting dialogue about tobacco use, you're identifying their level of dependence, and then also it's providing NRT recommendations if that's something that they're interested in learning more about, you can assist them with that. And then I know we didn't get to talk about it, but the slides I saw of Ryan's, that importance, confidence, and readiness scale is excellent to use with patients. And then that decisional balance matrix sheet is really great as well. Thank you.
Thank you, Amy, so much. I appreciate it. Next, we have Catherine. And Catherine, whenever you're ready, have you and the Smoking Cessation Leadership Center trained community health workers, promoters, or other peer community service providers on tobacco cessation treatment using existing cessation tools? And if so, please include any challenges and successes you encountered and potential barriers that agricultural workers may need help in overcoming.
Great. I mean, I got this question and I was like, let me add it. But I wanted to thank all of those who went before, because you've actually touched upon quite a few of the things that I was thinking I needed to talk about. So I think when I did get this question, though, I was really taken aback about like, what is it that our center has been able to do over the past 20 years? Because that was really probably one of the first questions that we asked ourselves. And knowing what you guys know now, that there is evidence-based treatment out there. You heard from Ryan talking about the 5 A's. I like to look at that almost like a 3-legged stool, you know, where you've got counseling, medication, and social support being the 3 legs that keep that effort strong. So with counseling, you're looking to relearn life without cigarettes or tobacco. With medication, it's all about withdrawal symptoms and making it easier, sort of physiologically. And then with the medication, to ease those symptoms and just make it easier on their body. And then with social support, having people believe in you, being able to find friends who don't smoke or support your decision to quit, alternative to smoke breaks, wellness breaks, all of that. So all that kind of comprised, just sort of looking at it like that, we really work to try and make the cessation piece as simple as possible, or maybe we should say doable, right? So that people will want to be able to embrace this and feel empowered to go forward and become an interventionist, if you want to call it, or an ambassador. And we really realize that none of any of that evidence base can be done without building partnerships, because here we are coming in, we're the experts, we can say we know how to help somebody quit. We know the evidence base, but we really can't do it without the folks who know really what is needed by the community. They understand the people, we understand the intervention, let's work together, can't do it without you. So building those strong partnerships in the communities that you want to work in are essential to going forward. And none of any of what you saw before can be done working with these particular populations without culturally tailored approaches. So that social support leg of the 3-legged stool, we have found to be so important, and having someone who's a peer or a member of the community offering to help somebody quit smoking is very powerful. And finding somebody, whether it's a clinician or a community health worker, a promotores, whatever that might be, that even looks like you, speaks your language, maybe they are quitting at the same time or have quit, right? So they can really be offer that peer experience, is very empowering. And it can be a clinician, right? Or it can be a community health worker or a certified peer worker, as I mentioned. And also community pharmacists are also an excellent addition to help build sort of that army of interventionists so we can combat the tobacco industry. But how we've gone about sort of educating these ambassadors, you heard a lot about it today. We really believe in the clinical practice guidelines, the 5 A's, this 3-legged stool approach. And not everyone, as you heard too, has the time, or maybe they don't all feel comfortable doing the full intervention. And so our center actually created Ask, Advise, Refer, you know, in the spirit of trying to make everything seem doable, but also in the spirit of saying there is no excuse to not do anything, right? It can be as simple as that. And it isn't shortening it. What it is doing is creating a team approach. So the individual could ask, as Ryan had said, what is it, fumas or something like that, and you advise, consejo, and then you referencia, I'm practicing my Spanish, for refer. But what you're doing in that refer is referring to somebody who can continue all of the A's, right? The gold standard. You're creating a team approach to help that individual quit smoking. And if that's somebody in the community, there are migrant worker community centers through HRSA. I can send a chat in there for you guys to see, or if it is the quit line, you heard again, they come in multiple languages. Spanish is probably one of the prime ones, and the map of the quit lines will tell you everything that is offered that way. And Missy, you can put the slide up just to show some of the resources there. So 1-800-QUIT-NOW is the number. I know you've heard it earlier, but I'm going to keep on saying it because it is there even for individuals who say what you might call proxy, want to help somebody they know quit smoking. So I highly recommend it. It will double an individual's chance of quitting. It has various languages and services, culturally tailored materials that are available, and somebody can call it from wherever they are. There's a router number that will refer them directly to the service in their state. It can help them understand what medications may be covered. So I can't say enough about that. And then you also heard a little bit about RX for Change at the beginning. Ryan was saying those slides that he had. Well, we've worked with the RX for Change team here at UCSF. And we have not only a peer-to-peer curriculum, so if somebody, maybe a community health worker wants to listen, look at it, learn, there's facilitator notes underneath that explain how they can train people or how they can talk to people. And then there's Spanish handouts there that are available for those who are working with Spanish-speaking clients. So that's also a great resource. Smokefree.gov, you can see on this slide, has the en español conviertas en exfumador. Again, I'm trying. And there's for teens. They have quizzes and tips, plans, messaging programs. So highly recommend the smokefree.gov. National networks as well. So the CD Office of Smoking and Health really puts a lot of their efforts into having, you know, a peer support group. So having somebody from your community who understands tobacco and tobacco dependence and how to help somebody quit. So those two networks are the ones that I brought up, but there's 12 others. There's, you know, these two here are for rural populations as well as for the Hispanic community. So go ahead, take a look. And if you're looking for the migrant and seasonal Head Start centers at HRSA, those are also available. I'm going to send those in the chat when I'm done here for all of you. You can search and find ones that are in there. So all are culturally relevant tobacco use interventions, and all of these can help double a smoker's chance, an individual's chance of quitting. So a little bit about barriers or challenges for us.
I do apologize, but we are at time.
That's fine. I'm just going to say language, transportation, connectivity, and just make sure you do know that for connectivity, that there is text-based support like WhatsApp and Messenger services that can give that for free. So that was it.
Thank you. So our webinar is scheduled to end at, I believe, here shortly. So Deb and Maria, you know, if you guys could do an amazing job and maybe just sharing what you have to share and as quick as possible, and then we can dive into a quick evaluation process. And if there's any questions that you guys have that we don't get to answer, those can always be sent in the chat, in the Q&A. We can always email responses to those later. But with that being said, thank you again, Catherine. Next, I'm going to introduce, well, Deb Salazar, your question. So whenever you're ready, Deb. Your question we have put up for you today is to, I don't know if, there you are. Okay, couldn't find your image there. But if you can please share health educational tools and outreach methods your organization has implemented to educate agricultural workers on the health risks of tobacco use and encourage them to quit?
Yeah, perfect. Thank you, Missy. And thank you everyone for having me. So I run a medical mobile unit here in northeastern Colorado. So we actually go out to the farms, the greenhouses and the dairies in our service area. So we go out to the folks and stuff, having them come to us. So part of what we do every time with every patient is the tobacco cessation is part of our quality measures. So during the questions on social history, there is a question about tobacco and if they use. And then if they say yes, then my MAs will indicate that to the provider. The provider will talk to them. And of course, we have information for the Colorado quit line. They're not always, the workers aren't always forthcoming, or they just don't understand that it's an issue. If they do say yes, we have other material that we can hand out to them for sure. We have found though that they'll say, no, we don't, I don't smoke. And then we'll actually go back to the site to drop something off or something, and we'll see them smoking. So we just let them know we're there to support them and to help them when and if they decide to quit using tobacco products. So yeah, that's what we do. Thank you.
Thank you, Deb. I appreciate it. And so, Maria, whenever you're ready, your question is the same. If you can share any successful health educational tools and outreach methods your organization has implemented to educate agricultural workers on the health risks of tobacco use and encourage them to quit. I'm not sure if Maria might need help being unmuted, but if in case she is in the non-panel Zoom link.
We're getting that all set up right now.
Thank you. Hey, Maria.
Hello.
Hi, Maria.
Hi. Hi, everyone. Hello. Good afternoon. Okay. I'm gonna be very with my time, and I just wanted to say that the tools that we have here at Familias Triunfadoras for our farm workers is to give some education, and most of the education information where they can go and get resources, how to quit the tobacco. And I know that some of these farm workers there, I have like 3 or 4 testimonies that some of these farm workers are from Mexico. So when they come here, they start smoking tobacco, chewing tobacco, because that will help them, on their emotional, like anxiety or depression. But we go out and give some resources. We talk to them and the information where to go. Like we have the Aliviane clinic where they can go and get more resources. Also, we give them some presentations, workshops, and also we give them this application NCRN because they have a lot of resources to help our people, our persons to help them quit on the tobacco issues. So we have a lot of resources here at Familias Triunfadoras. Do
Thank you so much, Maria. I appreciate it. And those pictures were provided on the PowerPoint slide by Maria. They're wonderful, amazing pictures of them doing outreach. A lot of some of the produce out here that's harvested are onions, and you can see that they are at an onion farm. And so thank you again. Great work that everyone is doing within your organization, each and every one of the panel speakers. And Brian, thank you as well. We apologize, but we are going to just, at this point, this concludes the portion of our webinar.